afternoon, everyone. Welcome, welcome. I just want to welcome everyone. Thank you for those who have tuned in a little bit earlier, before 2. So we just want to quickly welcome you. And John's going to give us a couple of tips before we begin with our exercise. So John, you go right ahead.
Hey, I want to welcome you to the Emory Disease Research Center. And today, I want to make sure you get a comfortable chair, and I want to make sure you get some tape if you want to, and 2 water bottles. And today, can you just get a trash bag? Because I'm going to show you some exercises you can do with the trash bag for resistance. So go get your chair, go get 2 water bottles, and if you want to get some tape, you can. If you just want to get a trash bag, go ahead, because we're going to improvise today and have a great time. So, Camille, you have it.
All right. Okay. Welcome, everybody. And this is episode 10. Welcome to BrainTalk Live. We are 1 month into our virtual community engagement effort, and we just want to thank everybody for joining us. So as everyone's coming online and we're offering a little bit of technical assistance, I want to give you a little bit of background as we wait for the arrival of the rest of our presenters. And before we begin with our exercise demonstration, so you heard just really briefly from John Lewis, and our program has been offering these educational face-to-face opportunities. And right now, because we're unable to do that due to the shelter-at-home requirement, we've had to really look at, these innovative ways to still bring you the same quality content, but in a virtual environment. And if anybody can let me know if they're getting any feedback. I'm hearing feedback. If you are, can someone text me to let me know? Okay. Is that any better? Okay. All right. So today we will be featuring several of our Emory experts, and we've been bringing you some main topics around general Alzheimer's disease. Still hearing feedback. Okay. Give me just 1 second. Let me look into one other thing here.
Hey, everybody.
Hey, welcome.
Thanks. How are you?
Okay. Still troubleshooting. Every week is a new week to determine and improve and learn as we're in this virtual environment. I am still getting a little bit of feedback, so I apologize. We're right at the top of the hour at 2 o'clock. So I'm still talking. So if you guys are still continuing to hear feedback, can you let me know?
There was a little bit of scratch in the back, scratchiness.
Yeah. I'm unplugging a couple of things to see if that helps. Okay. All right, well then I will talk briefly because my sound this week is not that great. Today you're going to hear from Dr. Monica Parker. She's going to talk about Alzheimer's disease and other dementias. And then you're going to hear from Dr. Whitney Wharton, who's going to talk about blood pressure and brain health. Okay. And then after Dr. Wharton, we're going to hear from the social worker, licensed clinical social worker, Jocelyn Wise. And so she's going to give us some insight about creating a routine. We've been talking about dealing with anxiety, depression, and other issues around stress and how to manage that. And so right now we want to talk about, we're 30 plus days into this, and then we got the news yesterday. So this is really an unprecedented time. So um, hang in there with us. We want to continue to be a voice of reassurance for you. And again, we've gotten hundreds of questions, some of them very technical. Again, our first point of guidance is going to be to talk to your primary care doctor. Again, we're giving you some general insight, framework, and general information all in 1 hour. So we're really honing in on those frequently asked questions that we can tackle in under an hour. So if we don't get to all of your questions, please know that you can go to our website at www.alzheimers.emory.edu. Okay. Also, you're going to hear from Crystal Johnson, who is the infection control prevention manager with Emory Healthcare. And she will be closing us out with some um, infection control and countermeasures. So these are some of the very general and basic content that we cover every week. So if you're enjoying this, please come back. This is our 4th episode that we've been hosting consecutively every Tuesday at 2 o'clock. So I think I've done all of my housekeeping. This will be recorded, so it will be available. We'll send a YouTube link out and then a PDF of all of the resources as well. Okay. All right. Well, without further ado, I'm going to turn it over to John, who's going to give us an exercise demonstration. So one thing I'd say is do this at your own risk. And secondly, make sure you have a good chair, a firm chair. And I think he advised some of the people that just came in to get, I think you said water bottles and canned goods. So I am going to turn it over to John.
Hey everyone, today I want to show you some simple exercises you can do and ideas you can do. I've taken some water bottles and I've gotten some tape and I'm making my own little ankle weight that I'm going to use. And with those, I just tape it around my ankle and I can do rehab as well. So I'm gonna show you some rehab exercises you can do before we get into our cardio and our upper body and abs. All right, you can sit back even if you don't have them. Lift your leg up. Remember the weight, the water bottles are your resistance, and extend. We're working those quads so we can save the knees, and we're doing a little rehab for the knees because you're working on those quads. There you go. And good. Let's get the other leg. And boom, there we go. A great way to get good resistance so you can work those quads. Keep it going. And good. And let's say you just want to work those abs. We want to work one side of the abs because we have our resistance with our water bottle. Even if you don't, we're going to do 5 reps. 1, 2, 3, 4, and 5. Good. Let's do the other side. And 1, 2, 3, 4, and 5. And if you really want to engage those hips and work on those love handles, you can lift the leg up and go in and out. Let's do 5. You ready? And go. 1, 2, 3, 4, and 5. Other leg and up. 1, 2, 3, 4, and 5. Great. Now, you remember when I said you have your trash bag and you don't have any weights at home? You know what you can throw in here? You can use your water bottle. You can use your shoes. You can use the shoes. You can use some shoes. You can use even your rice or couscous you can put in there. And as you put everything in there, tie it up And now you have built your own weight. So you can put it up to your level that you can do. So if you want to work shoulders, 1, 2, 3, 4, 5. Remember, we have to keep that upper body tight. If you want to work the lats, the shoulders, and the outer chest, roll. There we go. 1, 2, 3, 4, and 5. Next side and pull. 1, 2, 3, 4, and 5. And you can do all your upper body exercises with a simple trash bag, resistance of your choice, all your biceps, triceps, shoulders, and chest. So beyond that, let's get our cardio in. So get in your chair, and we're about to I'm gonna warm you up, and let's get it going. I'm gonna keep my resistance on. Here we go. Here we go. I need those feet bouncing, because we creating circulation. There we go. Watch it now. Hey. Come on. There we go. We working those hips. I got it. There we go. Come on. Watch it. Watch it. Straight. Hey. There we go. We doing the hamstrings right now. Let's go. There we go. Come on. Angle. Yep. We actually engaging those hips, out of hamstrings. There we go. Come on now. Look. Feel good now. I want y'all to feel good. Come on. There we go. Give me them hips. Engage them a little bit more. There we go. And good job. Good job. We're going to keep it going. Can I get that waistline now? Woo! Come on. Here on the floor. Let's rock some more. Come on, I need that waistline. Come on. Let's go. And let's rock some more. Hey, bound together. Get your hand on. Get your hands on your hip. There we go. Come on now. There we go. Here we go. Give me a look quick. Let's go now. Work, baby. Work. There we go. Baby. Work it out now. Work it out. Work out. Watch it. All right. Ready, let's go. On the way. Let's go. Good job. Great job. Great job. We're going to stay at it. Can I get a little bit of that upper body? I need to get a little bit of that upper body. We're going to slow it down a little bit.
Like a rainy Sunday morning makes me want to
Watch
stay
it.
there, twisted up all day long.
Boom. Elbows up.
You're my inspiration, girl. You
There
take
we go.
me places, put the words right into these songs.
There you go. Come on. Come on.
Steal kisses undercover, babe.
Come on.
When I see your face.
Come on.
I swear God made you for
Watch it now.
you, baby. I love all you make it easy.
Pray, pray. Good job. Remember, I want to make sure we get a lot of stretching in, but I'm about to get that core right now. Here we go. There we go. Lean back a little bit. This it, y'all. We about to get those hands. There we go. Come on. There we go. Switch legs. I just need you to stay rocking with me now. Can we get both legs? Let's go. Come on. Come on. Come on. There we go. Y'all ready? Y'all ready? Let's do this. Oh, I want to hear you scream. Oh, 1, 2, and 3. Oh! Let's go. Let's go. Let's go. And stop. I know y'all want to continue on, but just a little bit of the ideas that you can do at home. Remember, use water bottles. You can use tape. Make your own resistance with a trash bag and make it your resistance. If it's 2 pounds, 3 pounds, 4 pounds, 10 pounds. So make sure you stay active. Make sure you keep moving while we're going through this COVID-19 and stay safe at all times. I want to thank you and see you later. Bye.
Thank you, John. Okay, now if you aren't moving, I don't know what. So again, we try every time that we are in person with our community partners, our heart moving, because we have come to realize that what's good for your heart is also good for your brain. So our first talk will be Dr. Monica Parker, who's going to be sharing information about Alzheimer's and other dementias. Each week we brought you a segment to highlight some of the clinical aspects and treatment and intervention aspects. So this week she is going to be talking about the other dementias, not just Alzheimer's. Alzheimer's is one type of dementia, but today Dr. Parker will be talking about the other dementias. So I'm going to turn it over to her, and then we'll do one more housekeeping check. Thank you, Dr. Parker. Unmute your line.
Can you hear me now?
Yes, there you are.
Okay.
Okay.
All right.
Start
In
from the
any
top.
event, sorry about that. One of the things that we talked about a little bit earlier, a couple of weeks ago, was Alzheimer's. One of the things that is important is that all different types of brain dysfunction, that's what I call it, is not Alzheimer's. We have said that Alzheimer's is the most commonly diagnosed dementia, but there are others. So are Alzheimer's and dementia the same thing? Keep in mind, dementia is a broad term and that there are different dementias underneath it. We talked about Alzheimer's. That's one of the spokes, if you will, on part of the umbrella. But the next most common is something called vascular dementia. So if you have diabetes or high blood pressure or heart disease, you are at risk for what we call vascular dementia. That's the kind of dementia whereby you don't get enough blood flow to the brain to make the brain work properly. Different parts of the brain may lose blood flow, and when they lose blood flow, the cells in that area of the brain die, like with a stroke. So some people may have a motor stroke that affects the blood flow in the back of their neck or their cerebellum, and they'll have difficulty with movement. Another type of dementia is a dementia that goes along with Parkinson's disease. You still may have some trouble with how you process information and think. Maybe you forget things, maybe you don't. But the mechanisms behind Parkinson's dementia are a little different from both Alzheimer's and also vascular dementia. That doesn't necessarily pertain to decreased blood flow to the brain. In Parkinson's, we have a part of the brain that deteriorates, the substantia nigra, that deteriorates. It leads to problems with somebody's ability to ambulate or to walk, to swallow in later forms, but also these persons may exhibit hallucinations. They don't necessarily have problems with cognition, but they may. Other types of dementia include chronic alcoholic encephalopathy. People who are excessive drinkers or chronic alcoholics have parts of their brain that are diseased and are no longer functioning. They may have motor problems or difficulty with their ability to ambulate. They certainly have difficulty with their ability to process information. Another type of dementia is something called frontotemporal, the frontal part of the brain, the frontal part of your brain that has to do with emotions, generally shrinks, and you may have some difficulty there. So as we all age, our brain shrinks to some degree, but it doesn't necessarily become dysfunctional. So under the category of dementia, there are many different types of dementia. As we talked about, more than 60% of all dementias may fall into the category of Alzheimer's, which is pathologically defined as the accumulation of something called A beta and tau proteins, followed by a vascular or a mixed dementia, which may have features that go along with both Alzheimer's, but also poor blood flow to different parts of the brain, vascular. Another type is frontotemporal dementia, where you have shrinkage of the frontal part of the brain. You may have some behavioral changes that go along with this type of dementia. It generally affects people a little bit earlier in life, maybe not after 65, but before. There's chronic alcoholic encephalopathy, or chronic alcoholism results in a type of brain dysfunction where you may have motor deficits, you may have cognitive deficits. All of these dementias, regardless of their etiology, eventually result in an individual's inability to take care of him or herself. And finally, the last dementia that I want to talk about is something called chronic traumatic encephalopathy. It's the type of brain damage that occurs when somebody has suffered an excessive amount of trauma to the brain. Yes, we think of boxers, but in addition to boxers, there are soccer players, football players, and people who are victims of domestic violence. Again, regardless of what the cause is, people's abilities to think, to process information, to reason, to ambulate or have good motor function are all affected by the type of brain deterioration that is going on. Now, that being said, are the treatments the same for all of them? The answer to the question is no. If I have Alzheimer's dementia, a doctor may prescribe something like Aricept or Memantine or Namenda, that's the name of it, or something called galantamine or Razodine. And that's effective for people who have Alzheimer's dementia. Those medications are not effective for people who have vascular dementia. If I've had a stroke, giving me Aricept isn't going to help or improve my brain function. One question that somebody has asked is whether or not chronic ECT treatment, electric shock treatment, can result in a type of encephalopathy. I will say that immediately following an ECT treatment, people do have some temporary kind of loss of memory and some dysfunction, but that's generally something that you recover from. Not knowing enough about what the person is getting the ECT treatment for, which is usually for treatment of depression that doesn't respond to medication, there may be other things that are involved with that individual's inability to remember things or to process information. But electroconvulsive therapy, or ECT, does have associated with it some temporary memory loss. It's not regarded as chronic. Just like if you have a seizure disorder, somebody who's had an acute seizure may be immediately unable to process information and may not remember something right away. Again, the treatments for the different types of dementia are probably likely going to be different. Inasmuch as the person asked about ECT treatments and depression, we have a tendency to look at depression as what we call a pseudo-dementia. Why do we say that? Because people with severe depression a lot of times don't function well. They don't process information, they can't remember things, they don't focus. But usually when we address the depression, those functions, those brain functions generally return and come back. So it's a treatable kind of brain disorder. Depression is something that we can treat. There are medications, there's ECT, there are other therapies we can use to treat that. For any dementia, there is no medical treatment, no known medical treatment that's been shown to be consistently effective. And the last thing on this, when we start talking about dementias, in the era of COVID or Corona-19, we do have a lot of older adults and people who may be experiencing delirium because they have a very high fever, because they've become dehydrated, and maybe because they have taken their medications incorrectly. Delirium is not a type of dementia. It is an acute medical condition that is life-threatening. So when somebody was functioning fine on Sunday and here it is Tuesday and all of a sudden there's a very sudden and acute change in how they process information, how they're thinking, that's something that generally looks like it might be a medical emergency for which you really need to seek out medical assistance and medical care acutely and quickly. Delirium is a medically related problem that's generally temporary. So if I'm acutely dehydrated because my sugar levels are entirely too high, my glucose should be between 60 and 120, but my glucose is 500. As soon as I'm hydrated and they get my glucose or my sugar numbers back to where they're supposed to be, my cognition should improve. But delirium, as distinguished from dementia, is an acute, temporary, should be regarded as an acute temporary problem that can be managed medically. Dementia, on the other hand, regardless of the type, is a chronic, progressive, deteriorating neurologic condition for which there is no cure. And with that, I think I have some questions, and I'll try to answer through the quote as much as I can. Thank you.
Okay. Thank you, Dr. Parker. And so Dr. Hepburn brought up a good point too. He said, we definitely want to mention that anywhere from 6 to 9% of dementias occur in people under the age of 65. And so Dr. Parker talked about FTD and CTE and all these, sort of alphabet soup here when it comes to all the different types of dementia. But the take home is that, there are different types of dementias. There are different types of treatment. And in 25% of those cases, they present very different for the caregiver. So if you just want to take 1 minute to sort of address those unique situations for some of the dementias, and then I have into caregiver stress and how to respond.
Cornelia, you kind of broke up at the end.
Okay. All right. Well, let's go ahead and transition to Dr. Whitney Wharton. Dr. Parker's still muted. And while we're highlighting or addressing Dr. Wharton, what I want to mention is individuals have had some difficulty accessing the link. And just want to remind people, when you're entering your email address, to just make sure you're entering it correctly, because that is how you receive the correct link. And if you don't enter your email address correctly, we can't get that information to you. Okay, so Dr. Wharton is going to share with us information about the correlation between our brain health and blood pressure. Dr. Wharton.
Thank you so much, and thank you to the almost 200 people that have signed on for this webinar today. We really appreciate it. And as Cornelia mentioned, you know, all of us are scientists and physicians at Emory and the Alzheimer Center are still here, and we're still working very hard to make sure to try to get you the information that you need. So thank you very much for tuning in. I am a Alzheimer's disease prevention scientist. And what I do is work in tandem with investigators who are currently trying to find a treatment for Alzheimer's. I'm specifically researching people who are currently healthy, but are at risk for Alzheimer's disease due to a number of things. I have studies that enroll only women. I have studies that enroll caregivers. I have studies that enroll African Americans and people who are at increased risk for Alzheimer's due to vascular risk factors. And that's what I've been asked to speak about today, specifically vascular risk factors and high blood pressure. So in prevention research, what we do, again, is try to get a group of people who we know are at risk due to one or more factors. And then instead of trying to look at individuals who already have the disease and get the brain disorders that happen with Alzheimer's, the plaques and tangles, instead of trying to get those out of your brain, I'm trying to prevent those brain changes from happening in the first place so that we don't have to worry about getting them out of your brain. So, how do we do that? So, we have to do things, we have to identify factors that are able to prevent Alzheimer's that hit a couple of key points. And I think there's 4 key points that I really try to hit in our research program. One is that we try to identify factors that are linked to the Alzheimer's symptomatology that oftentimes you would associate the symptoms of Alzheimer's. So the memory problems, the repetition of words, visuospatial difficulty, those types of things. Number 2 is that we try to identify factors that are linked to the specific brain changes that we know are related to Alzheimer's. So the accumulation of the plaques and tangles that Dr. Parker referred to. Number 3 is that we try to identify factors that we can change that happen during middle age, because we know that middle age is the time of life when the brain changes start happening way before the cognitive and the symptomatology of Alzheimer's actually happens. So by the time someone is repeating words and phrases and having trouble navigating in their world, the brain changes have been happening for a decade or more. So we're really trying to hone in on midlife brain changes. And the last is that we really try to focus on factors that are treatable and reversible. So as Monica mentioned, things like, delirium, that's something that is treatable. Depression, that is something that is treatable. And so midlife factors are something that we're really interested in and things that we can change. And one area of research that I'm particularly interested in, something that I think checks all of those boxes, are midlife vascular risk factors. So this is high blood pressure, this is high cholesterol, this is diabetes, obesity, and being physically inactive. we know that these things during middle age contribute to later probability of getting Alzheimer's and vascular dementia, or not getting Alzheimer's or vascular dementia. I should also mention that all of these conditions are additive. So your increased risk for Alzheimer's and vascular dementia goes up the more of these symptoms, the more of these conditions that you have. So if you have high blood pressure, you know, that's a risk for Alzheimer's. But if you also have high cholesterol, also have diabetes, also are overweight, all of these sort of add cumulatively to your later risk of getting Alzheimer's disease. So because I'm interested in studying blood pressure and vascular risk factors, a number of us, you know, we started doing this about 20 years ago, 2 decades ago. And one of the first studies that looked at this found that individuals who had the systolic number, so the average blood pressure, the optimal blood pressure should be about 120/80. And that top number that's 120, people that had a very high number, specifically 160, we found that in a huge group of people, the people that had high blood pressure were more likely to get Alzheimer's disease and vascular dementia than people that had controlled blood pressure. So what happened a couple of years later was that we said, okay, well, hypertension, you know, high blood pressure is a very common disorder. It's the most common, you know, clinical issue that we see in clinic. So what about people who are taking blood pressure medicines? Are they less likely to go on to get Alzheimer's than people who are not on a blood pressure medicine? And what we found was that individuals that are on a certain type of blood pressure medication are less likely to become afflicted with Alzheimer's disease. And those medications act on a system in our body called the renin-angiotensin system. And those medications are ACE inhibitors and angiotensin receptor blockers. So we think there's something specific about these 2 types of blood pressure medications that might have an extra benefit in helping with Alzheimer's. Above controlling blood pressure and reducing your risk for Alzheimer's and for vascular dementia that Dr. Parker talked about. So, you know, as I said, you know, to hit kind of those 4 key factors, we need to make sure that these are that the questions and the factors that we're targeting really hit all of those 4 key areas. And one of those is that, you know, we want to make sure that the issues that we're targeting act actually on the brain changes that are associated with Alzheimer's disease. So what we did is take individuals who are already starting to be affected by Alzheimer's, so individuals that have mild cognitive impairment. So we took a group of about 800 people, and everyone also, to be included in the study, they also had to have high blood pressure and be on a blood pressure medication. So we took about 800 people, and half of them were on these medicines that we think are good for Alzheimer's, and half of them we think are just as good for controlling blood pressure, but might not have the same capability of preventing Alzheimer's. And what we found was what happened was within 3 years, individuals on these specific types of blood pressure medicines were less likely to progress from mild cognitive impairment to Alzheimer's disease. So that was really interesting that we found that result. In the blood pressure medicines, I'm specifically talking about the ACE inhibitors or the ARBs. ACE inhibitors are medicines that end in pril. So ramipril, lisinopril, and then the ARBs are medicines that end in sartan. So losartan, telmisartan, candesartan, those medicines really seem to have a benefit in not only controlling for blood pressure, but we think that they might also have benefits in regard to Alzheimer's, and that they prevent the brain changes that are associated with those plaques and tangles. The other 3 types of medicines that are commonly prescribed are a thiazide, so a water pill like hydrochlorothiazide, a calcium channel blocker, and a beta blocker. So while those medications are great at controlling high blood pressure, if someone is at risk for Alzheimer's, meaning they're a caregiver, you're a woman, you're an African American, or a combination of these factors, we're trying to see if this specific class of medications is able to additionally help these people in preventing Alzheimer's. The other thing I said is that, we're trying to do something that's treatable and reversible. Blood pressure is something that is absolutely treatable and hypothetically reversible. Some people have a genetic predisposition towards high blood pressure, but I also just wanted to add that, when we're all kind of at home and stressed out, there's things that can raise your blood pressure that the more you can kind of mitigate those symptoms and mitigate those levels, especially, amid the COVID-19 pandemic, the better. So many doctors are available using telemedicine right now. So if you do have high blood pressure, make sure you're keeping your levels in check, and anything that you can do to kind of mitigate the stress. John Lewis did a really good job doing that. The more you can exercise, the more that you can control your diet and do things to kind of get your blood pumping and get your body moving in this time. That will really help. And then if you are prescribed blood pressure medications, I know that it's a very tumultuous time, but make sure you take your medications and try to keep up with that.
Okay. All right. Well, I think there was a lot to cover there. And thank you so much, Dr. Wharton. If you don't mind, in the chat, if you can, Dr. Wharton, several people are asking for clarification on the medications. So do you mind putting that in the chat? And then additionally, you all, this video is being recorded, so we will repost it with the resources that we reference here today. So my take home was try to reduce your risk for chronic disease. That was my take home. So we're going to stay on schedule. So we've been talking about reducing your anxiety and your stress while we are having shelter at home and unfolding by the minute. So we've talked about addressing tips for caregiving. And so today, it's been over a month and we're kind of stuck. How do we do if you're a caregiver, if you're an adult taking care of yourself and others? We want to today with establishing a routine. So Jocelyn Wise is going to give you tips today on how to establish a routine. And so we have some great resources. Please make sure we have your correct email address. We're going to send out the correct link for next week's webinar along with the courses that we referenced today. So give me a second, Jocelyn, if you want to begin talking while I pull up the deck.
Sure. I feel like routines have never been more relevant for anybody right now. So we're going to talk a little bit about establishing routines in the context of caring for somebody with dementia, which honestly can apply to a lot of ourselves these days. Routines can provide a sense of comfort and a sense of control for most people. People who live with dementia thrive on familiarity because they tend to have trouble with a sense of time and their ability to organize tasks throughout the day. It's already becoming more challenging. So routines can take some of the pressure off of families when they're trying to function together. Routines also tap into activities that might be stored in the long-term memory of somebody's brain. So things like brushing teeth, knitting, yard work, things that we have done since we were potentially children are stored in those long-term parts of our memory that are less likely to be affected by an illness that's causing dementia, especially in the early stages. So having a routine that integrates those things at a very steady part of the day can be helpful to people who need more help and more cueing these days. Routines help to regulate mood for most people. So there's a whole area of talk therapy that focuses just on getting people active, behavioral activation. And part of that is because we tend to feel better when we do more things. So our mood, you know, if you've noticed symptoms of depression or anxiety, a lot of times the way that that manifests in our behavior is we do less. And then it can become a bit of a cycle where the less you do, the worse you feel. So getting into a routine that keeps you engaged in things that are meaningful can be very important. And lastly, routines can help care partners. So anyone who's taken care of a loved one before knows predictability is a good thing. Being able to plan around your day, plan for activities, and kind of have some sense of what's going on is helpful when you're taking care of somebody else. So routines, I'm a big fan, in case you couldn't tell. When you're trying to establish a routine, certain things you can be thinking about, you know, obviously the stage at which your loved one might be experiencing dementia is very important. Cornelia, if you want to go to the next slide. So actually following this today's webinar, I'm asking Cornelia to email out to anyone who's registered 3 different tip sheets from the Alzheimer's Association that are organized by stage of dementia, so early, middle, and late, with a bunch of ideas around activities that somebody can do. So think about the abilities of your loved one and what they're able to do. Think about their interests, things that they don't like. Some of these things have probably been the case for a long, long time. Think about strengths. I've certainly come across persons with dementia who have a lot of social skills intact and are able to interact, especially for short periods of time, very well, and get a lot of pleasure and joy out of that. So think about strengths. You know, people who were very strong in math and problem solving may still really do well with brain teasers and math games and number games, things like that. So think about catering routines to people's strengths. Think about the history of someone's daily structure. So is your person a morning person, a night owl? You know, catering the routine to the rhythms that somebody naturally has in their life. Maybe it's somebody who always got up really early to go to work, so maybe a lot of productive activities should be sort of focused in the beginning of the day, not so much the end of the day, vice versa. So thinking about energy levels and thinking about times when you notice that your loved one is fresher, or maybe when you're fresher, and structuring routines around that. And then sleep is so very, very important for everybody, but especially for somebody with dementia who needs all the rest and all the regulation that can come with sleep. So really being mindful of wake times and bedtimes, and keeping those in check. And I hope it goes without saying that care partners, your needs and the things that you enjoy are very important too as part of routines. I think there is a tendency for caregivers to put all of their thought and energy into what's going to be best for their loved one, but it's got to be something that's workable for you too. So thinking about how to meet some of the needs of everybody. Cornelia, next slide. A few things to think about in terms of personalizing routines. Can think about the types of newspapers, magazines, spiritual readings that somebody likes, making sure that those things are available. This is particularly important maybe for someone who's not living in your own home with you. If you have a loved one who's living elsewhere, making sure that they have access to the things that they have liked for a really long time, the newspapers they like to read, the magazines they finish from beginning to end, even if they're kind of just around, can be very comforting. Favorite TV shows, there's nothing wrong with watching reruns of things that you enjoy, especially if they're things that make you smile. Movies, radio shows, again, tapping into some of the familiarity that can bring comfort to people with dementia. Activities that people have, again, sort of logged in that long-term memory part of their brain can be really, really helpful. Games that they've played, card games or board games that have always been family favorites, arts and crafts that have been done for a really long time, hobbies like crossword puzzles, anything that was, you know, a long-term part of somebody's activities is more likely to be intact than things that were learned very recently or new things. So especially when caring for somebody with dementia, think about what are things that have been in their lives for a long time, or maybe things from a while back, dominoes or games that they played more in their youth that might be tapped into now. Familiar music, familiar radio shows, even recordings of old ones. You can find recordings of old radio shows anywhere now. You could look at YouTube, you could look at podcasts, spiritual recordings of people who are familiar. These are all things that might bring some comfort and steadiness to your routine. And then thinking about exercise. Not everybody loves going to the gym, and that's not very possible these days anyway, but some sort of movement that is the kind of movement that that you enjoy. That could be swimming instead of running. It could be yoga instead of cycling. It could be walking. Walking is actually one of the best physical activities for longevity for any of us. So thinking about customizing movement to what you and your loved ones enjoy. We also see quite a few couples who enjoy dancing because dancing has been a part of their lives for many years. It's a fantastic exercise from a cardiovascular, social standpoint. It's a great way of activating many parts of your brain all at once. And there's actually been some Emory researchers who really look at the benefits of dancing for folks with neurocognitive disorders. And then indoor and outdoor chores are a great activity too to integrate into your day, especially something that gets you outside in the sunshine, because sunlight can help with our mood, can help with sleep. So in many ways, sunshine is an important therapy. And the last slide, a few more tips on creating a personalized routine. Don't try to force a routine if your loved one with dementia gets stressed or agitated. Modify it, try it again another time. So it's trying to hit this middle path of finding predictability and structure in your days without it becoming a power struggle. Allow for some flex time and spontaneous activities. You know, you don't want to feel like a drill sergeant making every single minute of the day scheduled. Experiment with having, you know, wide swaths of time to shift from one activity to another, and also with having some parts of the day that are just kind of loose and unstructured. Do what works for your family. Sometimes in caregiver groups, you know, we get questions about napping. Is it healthy for somebody with dementia to be napping a lot? And I think the rule of thumb is if naps are not getting in the way of evening time sleep, then it's perfectly fine. If you're finding that your loved one needs naps in order to kind of maintain their energy and